2. It's a history of Mrs. M, who had come with history of jaundice for 1 year, pruritus, fatigue and altered bowel habits for 4 months. And she also complained of blurring of vision in bilateral eyes and also irritation of the eyes for the last 3 months. Past history, it was significant for the history of pancreatitis, the 2 episodes she had, one in 2015 and one in 2018. So examination showed a blood pressure of 100/60, vitals were stable. She was pale and ectric. There were scratch marks and shining nails. There was grade 1 clubbing. There was no lymphadenopathy or pedal edema. So the general examination also showed this. Can any of the first years say what the diagnosis as in spotter is? First, the eyes. What is seen in the eyes? Okay, so the first one, anyone?
Xanthelasma.
Yes, yeah, xanthelasma, and the lesions on the leg. In the background of a pruritus, probably a prurigo nodularis, and the eyes. Look at the conjunctiva and the cornea in this. Any guesses? Okay. So I'll come to it. So cardiovascular system examination was and respiratory system examination was unremarkable. Abdomen was showing a hepatomegaly 3 cm below the subcostal margin. Drop space was dull. CNS, there was no asterixis. There was no meningeal signs. Reflexes were 2+ bilaterally, and said there was no signs of cerebellar dysfunction. So investigation was this. Vitamin D was less than 3. PT and APTT was deranged. So anyone? Yeah. So anyone can guess? Conjunctiva. You can see well. There's conjunctival cirrhosis as well as corneal cirrhosis. So what can it be? It's a vitamin A. It's vitamin A deficiency. So what can it be syndrome? There is A deficiency, there is vitamin D deficiency, there is vitamin K deficiency. So what is? Yeah, there can be a there can be a cholestasis. So that's a chronic cholestatic syndrome. So her investigations were hemoglobin was 7.9, MCV was 93, total counts 11,400. The LFT was showing a direct bilirubin with a raised alphas. Other important investigations were immunoglobulins. IgG was around 3,000. Other ANA, AMA was negative. AIH panel was also negative. Bone mineral density was showing an osteoporosis, and IgG4 is awaited. Gastroscopy and colonoscopy was done, which is gastroscopy was showing a chronic active gastritis and duodenitis. So this was a MRCP finding on her. There was bleeding of the right and the left hepatic primary and secondary duct, and that is suggestive of a sclerosing cholangitis. And there was also there was thinning of the pancreas, suggestive of a recurrent chronic pancreatitis. So the final diagnosis was chronic cholestatic syndrome, sclerosing cholangitis. It can be a primary or a secondary cholangitis. Fat-soluble vitamin deficiency, ADK deficiency was found. Metabolic bone disease, the pruritus, and CLD with portal hypertension. So primary versus secondary sclerosis. So basically, sclerosing cholangitis is divided into two: the primary and a secondary sclerosing cholangitis. So basically, primary sclerosing cholangitis can be we can make a diagnosis of primary sclerosing cholangitis only if you rule out other causes like an IgG4 associated cholangitis, like AIDS-related cholangiopathy, or sarcoidosis, or sclerosing cholangitis in critically ill patients also can happen. Sclerosing cholangitis is a disease that can have overlap with other diseases, like mostly with an IBD, inflammatory bowel disease, and secondly with autoimmune hepatitis, also an IgG4 disease, and also hepatobiliary malignancies. So when do you suspect that the patient have an autoimmune hepatitis or an IgG4 disease? When there is positive ANCAs, mostly P ANCA, or a smooth muscle antibody positivity, elevated globulins. This is when you suspect whether the patient has an autoimmune hepatitis or a IgG4 related disease. So even in a primary sclerosing cholangitis, 10% patients can have an elevated IgG4. But serum IgG4 more than 4 times in the upper limit of normal is more suggestive of an IgG4 related cholangitis. Also, IgG4 related cholangitis occurs in male more than 40 years, whereas this primary sclerosing cholangitis is mostly between 30 to 40 years. And in IgG related cholangitis, it will be associated with autoimmune pancreatitis, whereas primary sclerosing cholangitis will be more associated with the inflammatory bowel disease. And there are new tests that is coming up. It's still getting standardized in non-European nations. There is quantitative PCR test. That is a ratio of the IgG4 and IgG1 RNA can give you a most can point more towards an IgG4 related cholangitis when it's more than 0.24. Also, there are tests that we can IgG4 plus B cell clones can be seen in IgG4 related cholangitis. Why is it important to distinguish between this primary sclerosing cholangitis and IgG4 cholangitis is that IgG4 cholangitis has a good response to steroids. That's why before making a diagnosis of a primary sclerosing cholangitis, we have to rule out a IgG4 related cholangitis. So when do we 7 to 14% of primary sclerosing cholangitis can be also associated with an autoimmune hepatitis. So when do we suspect this? When the SGOT, SGPT is markedly elevated, and also there are positive antibodies and there are immunoglobulins are high, IgG is high, then that's when you suspect an autoimmune hepatitis. Or the histology is showing some interface hepatitis, that is called when we suspect an autoimmune hepatitis. This also has good response to steroids, but however it's better prognosis than a classical sclerosing cholangitis, but worse prognosis than just as autoimmune hepatitis. But however, even if you give steroids, the injury to the long-term outcomes are not going to, not going to change much. Inflammatory bowel disease occurs in 70 to 80% of patients with primary sclerosing cholangitis, and they have 4 times risk of colon cancer. So and IBD in a lot of patients with primary sclerosing cholangitis will be asymptomatic. So it's very, very important in the primary diagnosis itself that we do a gastroscopy and colonoscopy with multiple site biopsies to rule out inflammatory bowel disease. Also associated with cholangiocarcinomas, gallbladder carcinoma, and colorectal cancer. It should be screened can be a first manifestation of disease and should be screened in the time of diagnosis itself. Usually screened with an MRCP and a CA19-9, and has to be tested every 6 to 12 months. So complications, as I've mentioned before, end-stage liver disease, fat-soluble vitamin deficiencies. As you can see, this patient has almost all the complications. She had a CLD with portal hypertension. She had fat-soluble vitamin deficiencies, metabolic bone disease, and and these people can have recurrent cholangitis and cholelithiasis and malignancies. Just one slide about vitamin A deficiency in primary sclerosing cholangitis. Almost 40% patients and 82% of pre-transplant patients were found to have this vitamin A deficiency, and supplementation of vitamin A is found to be beneficial effect on the hepatic fibrosis in these patients. And usually we give 2 lakh unit on the day 1, day 2, and 4 weeks later. So our patient, we gave vitamin E supplementation, we gave vitamin D supplementation, vitamin K injections we gave, and pruritus management. She had severe pruritus. You could see the pruritus, prurigo nodularis, and we were managed with emollients, antihistamines, and also deoxycholic acid. And we are working up to exclude a secondary sclerosing for cholangitis. So take-home messages: differential diagnosis to consider in a sclerosing cholangitis and to rule out a secondary cholangitis before making a diagnosis of primary sclerosing cholangitis, and some skin manifestation of vitamin deficiencies. Thank you.